Good morning and good afternoon. I'm Dr. Mee Hoong from Malaysia. First of all, I would like to thank the organizing committee allow me to share my experience in this 19 Women Cancer Initiative Tata Memorial Hospital Conference. I would like to introduce myself. I'm Dr. C from University Malaya Medical Center, Malaysia. I have no disclosure in this talk. First of all, this is my outline of my talk. We will talk about background of oncoplastic breast surgery in my country. So we move on to evolution and our experience and the cases. Yeah. Then I will conclude my talk. So the background of oncoplastic breast cancer surgery. So always all the surgeon and breast surgeon will think of how can I remove the breast cancer with large margin of normal tissue while at the same time making the patient looks as good as before. So this is the question that we always want to answer and we hope we can get our answer. So how to do this type of work that can help patient at the same time we don't jeopardize the oncological outcome. So chronological changes of oncoplastic breast surgery, we can see from here from 1973, Krill et al. Started partial mastectomy until 2005, Anderson have made these big changes. So we can see here oncoplastic breast surgery was started by Gamka et al. In 1997. Yeah. So oncoplastic breast surgery actually is a combination. Yeah. It's a combination of BCT, plastic surgical technique. So it's not it's more than a combination actually because it incorporate the philosophy of vision, passion, knowledge of anatomy and a lot more aesthetic symmetry and breast function. So the whole thing is aimed to have a safe oncological treatment as well as good cosmetic outcome. Yeah. So we don't want to jeopardize both of them. Yeah. So how can we achieve all these things? Yeah. So normally we can see here, okay, the evolving of breast surgery started from more is better. Yeah, we remove the whole breast, radical mastectomy, removal the muscle as well to less is more. And now we preserve the whole breast and we only remove the tumor with a normal breast margin and good margins, as well as we even want to improve the cosmetic outcome. Yeah. So how to achieve all these things? It's not easy, but it has evolved. Yeah. It needs to be tailored and multidisciplined and more attention to the cosmetic and prognosis. Yeah. So the approach have to be done by multidiscipline, including surgeon, radiologists, pathologists, our oncologists, yeah, okay, as well as the breast care nurses team, yeah. So we can see here again, it is a combination, yeah. It's an oncological resection or excision plus the plastic technique or knowledge, yeah, on the preserving of the cosmetic outcome. So the indication for oncoplastic breast surgery can be in when we need to resect more than 20% of the tumor and when the breast is very ptotic and big, macromastia, a lot of ptosis and a lot of asymmetry, and it needs a lot of large skin resection and it is inside the mammoplasty area and the tumor is at the difficult area like central, medial or inferior, as well as the patient already have previous plastic surgery. Yeah. So what is a contraindication? So as what we know, if the patient have extensive tumor, yeah, I don't think it is suitable for OPBBS. Yeah. And a low volume tumor, it really depends nowadays. And without ptosis, probably the replacement technique is more suitable. And we need a lot of large skin resection when the tumor involves the skin or the patient have previous history of smoking and a lot of expectation. Yeah. So the important is we need to achieve the balance line, yeah, to make sure that the oncological resection is really, really maintained with a good cosmetic. What is the oncological surgical margins that we are talking about now? Yeah. So as what we know, the negative margin is very important to make sure there's no reduce the recurrence. So as what we know, when we re-excise or we excise the margins, sometimes further re-excision is advocated because there is a lot of negative result from our first resection. Yeah. So in invasive carcinoma, from the latest guideline, there's no tumor on ink margin is considered clear. Yeah. So what about in ductal carcinoma in situ? The margins of 2 mm need to be achieved for this condition. Yeah. What about cosmetic outcome? So poor cosmetic outcome was noted after a lot of excision previously, and we can see here a lot of cosmetic problem was started when the tumor was resect more than 20% of the breast tumor breast ratio, as well as poor cosmetic outcome can result in poor quality of life as well for the patient, and patient do have very difficult experience on wearing their bra after surgery or that. Yeah. So with that oncoplastic technique, we can see there's a lot of techniques that have been started, has been and innovated, made by a lot of surgeons nowadays. And we know that the technique of reconstruction of partial mastectomy defect is a lot better with the plastic technique, and it can avoid mastectomy. So the benefit can be, we do have reshaping immediately, we can do wider excision, and we can go for extreme breast conserving therapy. So factors we really have to consider is the ratio that we are going to excise, the location, placement of the incision, as well as so on and so forth. Yeah. So the principle of breast oncoplastic technique has been popularized, and we know the famous our breast oncoplastic surgeon, Dr. Macmillan, have come out and tell us this graph is the most important graph that we need to remember, and the algorithm how to choose the technique when the breast size is whether they are low breast volume or medium or high breast volume or ptotic breast. And as well as classification, how to choose the technique according to quadrant by quadrant. And we also have a lot of principle after the introduction of the technique, including level 1 technique, level 2 and level 3, and all this is according to tumor to breast ratio. So let's have a look on our experience, and we are having this transition from a normal breast surgery service to breast oncoplastic surgery service in my center and my country as well. So we have published a paper last year in terms of discussing about oncological safety and complication from our center. So we have collected our patients' data from January 2011, which is the start of our service, until December 2018. And the follow-up was started in January 2011 until 2019. And a patient who underwent oncoplastic breast surgery, level 1, 2, 3 was recorded, and the ethics was approved by our center. So this is the types and the number of cases that we have in our data. 75% have level 1 as compared to 9.7% in level 3. So the number of cases that we have and type of cases can be seen here. So we do a lot of mammoplasty, but our patient's breast is not so ptotic. We have one is very, very ptotic, but the rest is about cup C normally. And this is our volume replacement cases. And the demographic cases that we have, our Chinese ethnic group is the highest group in our center because we are in the rural, we are in the urban area. The size of the tumor that we have generally is about 2 centimeter to 2.3 centimeter. And we have majority of them are invasive carcinoma or ductal carcinoma as compared to others. The specimen weights that we have achieved, the median is 57.5 for level 1 and 90 gram for level 2 and 3, the median specimen weight. And the outcome from our study, the level 1, there's no difference in our local recurrence and as well as distant metastasis. You can see the Kaplan-Meier curve here. There's no difference in the both group, which is level 1 and level 2 and 3. The short-term surgical complication, we can see we do have 2 or extra as compared to our level 1 wound adhesion. Yeah, is statistically significant as compared to others. There's no difference. Yeah, and we can see here, I would like to show some cases that we have done in our center. Okay, we have this 50 years old lady with right breast cancer, 1.5 centimeter at retroareola with lymph nodes of 0 out of 3. So we have done a right BCS sentinel lymph nodes biopsy and resortive flap for her. This is a post-op 1 week and post-op 1 year. Okay, this is a resortive flap that we are quite happy, and we are very, we like to do because we do have a lot of central tumor that before this, a lot of patients need to choose mastectomy without all this technique before. And we have published a paper on resortive flaps, our 5 years of experience as well. Yeah, before this, they do have a quite good experience for that. And the next patient, we have a 40 years old lady with fibroadenoma and 5 cm from, I just want to show our round block technique. Generally, we do round block technique in our patient that have periareolar tumor, which is like not close to the nipple. This is a benign disease that we have done. I just show the technique because can't really get hold of our previous round block technique breast cancer patient. Yeah, the photo. And the technique have been very useful to us. And then patient do very happy because they don't get an extra scar for the excision, and the nipple viability and numbness or sensation is all preserved. Yeah, okay, our round block technique, I think everybody will, and this technique is very easy to do, and a lot of my colleagues like this technique because most of our patient, the breast is not very toxic. And this is the post-op photo. And the third patient, we have a 55 years old lady with right breast cancer, post-lumpectomy, and we perform the BCS axillary dissection with thoracoepigastric flap, as well as we use the skin flap to cover the area that we are going to excise. This is an old scar that she has, the pre-op marking and intra-op picture. Okay, so we also have some patients that do have a small breast, but they have a lower inner quadrant tumor. And we have these 2 patients, left 8 o'clock and 9 o'clock, breast cancer, lymph nodes negative. So we perform BCS sentinel and a small mobilization with medium mammoplasty. This is a post-op picture of their photo. And we do have a lateral outer breast tumor as well in 5 o'clock and 48 years old. And she doesn't have any neoadjuvant chemo, but her tumor size is about 2 centimeter. White local excision was done with a wedge incision on the skin. And we re-centralized the tumor after the excision and reshaping with the lateral mammoplasty. And I'm so sorry because I can't get my pre-op photo for this lady. She had a very ptotic breast, cup D, 42 years old, came with left breast, 12 o'clock, breast cancer, about 2 centimeter from the nipple, grade 3 ptosis, and we perform a left wide local excision with therapeutic mammoplasty of inferior pedicle, sentinel lymph nodes, and contralateral symmetrization with a inferior pedicle as well. Okay, so what we have the cases, I hope it is a very, very good experience for us to get our patient to trust the procedure, as well as so that they can gain back their aesthetic outcome, even though they don't have to lost their breast, like they have to sort a mastectomy before this. And this is a summary of oncoplastic technique that I have prepared for my trainee as well. Do have a look. And last but not least, take home message from my side. Breast cancer, breast conservation therapy with radiotherapy is equally same compared to mastectomy. The outcome is the same. And oncoplastic technique do provide a lot of benefit to our patient and breast cancer surgery, and it can help us to achieve good cosmetic outcome without compromise the oncological safety. And however, training is very crucial, and to get the good experience before the surgeon can go for all this technique. And the transition of service is very, very timely and very important to improve and to help our patient, breast cancer patient, with a lot of benefit for them to go through breast treatment as well as oncological treatment. And last but not least, the long-term multicentric randomized control trial is very important. I hope after this conference, probably we can have a collaboration and networking to run a study on this. Yeah, thanks.